Okay, so this PowerPoint is over ambulating patients. So we're going to talk about how to ambulate. Ambulate means to walk. We're going to talk about how to ambulate using a variety of assistive devices. So the first one that we're going to talk about is a gait belt. So a gait belt wraps around the patient's waist to help stabilize during ambulation. Some things that we need to remember about a gait belt, and also remember that you do have some fill in the blank notes. The gait belt must fit securely but not too tight. So we want to be able to fit 3 fingers underneath the gait belt after we put it on to make sure that it's not too tight and they can breathe. Some belts have loops to pull on. If they don't have loops, you can just grasp the belt as a whole with an underhand grasp. But that's very important to know, the underhand grasp. So when we are walking with a patient, the gait belt allows us to hold on to the patient securely in the event that they get dizzy or they fall or whatever. It gives us some extra support. The gait belt should be grasped on the back, and we're going to walk slightly behind the patient. We are going to be on their weak side. So it's really important to understand that the weak side of a patient depends. So if they had a brain injury like a stroke, if they had an injury on the left side of the brain, then the right side of the brain would actually be our weak side. They have symptoms on the right side. So that's with brain injury. But if they had a just like a knee replacement on the right side, then obviously the right side would be their weak side, and that's where we would stand. The transfer belt or gait belt should be applied over clothes and not over bare skin. So continue to be alert if the patient acts like they're going to fall. We always want to be cognizant of that. Remember, think about our patients. They're older. They're more at risk for falls anyway. They are on a lot of different medications. They're in an unfamiliar environment. So anytime a patient falls, there's a lot of things that we have to do, and you'll have to jot this down or type this. This is not on your notes, but if a patient falls, then number 1, we protect their head and neck. Number 2, we call the doctor to let him know. He will probably order a scan to make sure that they didn't hurt their neck or their spine or their head. 3, we get their vital signs. 4, we ask them if they're hurting anywhere where they're in pain. And then 5, we have to fill out what's called an incident report. So let's say that we're walking a patient and they say, "Oh, I'm getting dizzy. I'm about to fall." So we can ease that patient to the ground like he's doing. We can grab underneath their armpits and kind of ease them and lower them down to the ground. Even if we ease that person down to the ground, that is still under hospital regulations considered a fall. So we have to do the same thing that we would do if the patient just actually fell. But it's so much better to ease them down to the ground than to actually fall. So again, after they have fell or we've eased them to the ground, do not move the patient unless they've been examined for any injuries, obviously. File an incident report and then call for help, and then don't leave the patient. You're going to stay with them. Here are the answers to your notes. You could do 2 to 3 fingers for this one, but here are the answers if you need to stop this and look and make sure you've got all your blanks. So these are some examples of things that would be what we call contraindicated, meaning we should not use for a gait belt. So anybody with like a feeding tube, a permanent feeding tube, which is right here, an implanted pacemaker right here, an ostomy, those things would actually cause more damage if we put a gait belt over them. And also pregnant ladies, we would not put that over a pregnant belly. So that's gait belt. So the thing that I need you to understand is that no matter what we ambulate a patient with, we are always going to have a gait belt on them to have a good grasp on them. So let's talk about crutches. Crutches, we actually have a few different types of gaits. Gait, in our case, means walk. So why is it important for patients to ambulate early? It's important because we talked about all of those consequences that can happen with immobility, blood clots, mineral loss, atrophy, contractures, all of that. So we want to, even if the patient needs a device, we want to get them up. Depending on the patient's injury or condition, that determines what kind of assistive device that we give them. Crutches are artificial supports that aid the patient who needs help walking. You've probably all seen crutches. We're going to talk about 3 different types. Crutches are prescribed by a physical therapist or a physician. I can't, as a nurse, just say, oh, you need crutches and hand them to them. So a physical therapist would fit the crutches to the patient and teaches them the appropriate gait depending on their injury. We have 3 main types of crutches. The first ones are axillary crutches. Those are the ones that you see most often. They are used if someone has an injury for a short amount of time. The problem with these is that patients have to bear weight on the handbars. So you have to have some good coordination, a good sense of balance, and some good strength in your wrist and hands. So we would not recommend these for older adults. Forearm, also called loft-strand crutches, they attach to your forearms. So these are used long-term for people with residual weakness or paralysis in both legs. And this is an example of them. They attach here, so you still have to have a good sense of strength in the wrists and the forearms. So for those people who can't bear weight on their forearms, we have something called platform crutches. And platform crutches are used for those people. And they're literally like a platform. So their arm is flexed at a 90-degree angle, and they're kind of bearing weight here. So if we looked at these are forearm, also called loft-strand crutches. This is a platform crutch. And these are axillary crutches, and they would be used short-term. So when we talk about fitting a patient for crutches, we're going to refer to axillary crutches for our purposes. First of all, they should have good shoes on, walking shoes that they can't slip or slide on the floor. The crutches should be 4 to 6 inches to the front and 4 to 6 inches to the side of the patient. Axillary crutches should be adjusted so that they are 2 inches or 3 fingers between the armpit and the axillary bar. If we bear weight down on the, if we just, and you'll see a lot of people who just like, they bear their armpit weight on that axillary bar, there are nerves in there. And we can actually end up with something called crutch palsy, which is kind of like a temporary paralysis or nerve damage of those nerve endings. And it can go all the way down to the fingers. And then your elbows are just kind of barely flexed as you hold on to the handbar. It's important that you watch these videos that I made. I did them in class, so they're a little loud, but, and then I think I did tell you about my situation at the Fountain City Duck Pond at one point, so there's some comedy in there, I guess. But it's important that you watch these to kind of get a visual as well. And then here are your notes, fill in the blanks. All right, the next thing that we're going to talk about are canes. We have a few different types of canes. We have a quad cane that has 4 tips, tripod 3, and then a standard single tip cane. You're going to see this one, the standard, in our video. This is a HEMA walker. So this is considered a cane that they can put on one side of them. It's just, it kind of looks like a walker also. Here's a video to watch about using HEMA walker. I would encourage you to watch this after you've watched this lecture. So a HEMA walker is used for patients with hemiplegia, so paralysis on one side of the body, either left or right. So how I decide to use a cane versus a walker. A cane is used for someone who has a weakness on one side, so the left side or the right side. A walker is used for someone who has just an overall sense of weakness or an overall poor balance. So with a cane, remember, I'm always going to have a gait belt. So I would stand on the weak side of the patient with the gait belt, and I would tell the patient to put the cane on their strong side. Okay. So again, if I had a right-sided stroke, the left side would be my weak side. The right side would be my good side or strong side. So that would be where the cane would be. I check the tips at the bottom, the rubber tips, and I want the cane to be 6 to 10 inches away from that unaffected side. How we know it's tall enough, the handle should be at the top of the hip bone, and then the elbow is just barely flexed, again at a 25 to 30 degree angle. The cane has a few different types of gaits or walks also. We have a 2-point and a 3-point, and then there's a certain way that you walk up and down stairs. So again, these gaits are, I have gone over these gaits with you in those videos, so that's why you need to watch those. Same thing with crutches. Crutches has a swing to, swing through, 4-point, 2-point, and then there's also a 3-point. The 3-point is not on the video. I'm going to put little instructions together for that one for you. So any healthcare professional can adjust the height of a cane. That is false. It needs to be a therapist. And then you'll see me talk about walking up and down stairs with a cane. So with stairs and a cane, we remember good guys go first. So we always step up with the good leg, and then the cane and the weak leg come together as the second step. Same thing. You just reverse it going down the stairs. And here are your answers. This one, cane should be 6 to 10. Sorry. All right, walker, four-legged device that provides support. Again, used for patients with an overall sense of balance. They may not have leg injuries. They may just be older and weak and more of a falls risk. So again, just like the cane, the walker should be at the hip, the top of the hip joint. That's how we know that it's tall enough. And then the elbow is barely flexed at a 25 to 30 degree angle. How to use the walker, we tell the patient to lift the walker. We don't slide it forward because it could slide out from underneath them. We start, the back leg of the walker should be even with the toes, and we start inside the walker. So we lift up the walker and we put it slightly forward, and then we slide our weight and put it in and step into the walker. And I'm going to also make a video for that for you as well. But the big thing is sliding the walker is very dangerous. So we want to encourage them to lift. And here's your answers. So when we talk about safety checkpoints, so be alert to the patient if they start to feel weak or dizzy. If a patient starts to fall, do not try to hold the patient up. Brace them. Use your body to brace the patient down. Grab the axillary area. If the patient has a gait belt on, keep a firm hold on it, obviously. Ease the patient to the floor, protecting their head and their neck. Do not leave the patient. Call for help. And do not move the patient until they have been examined for any injuries. Again, even if you lower the patient to the floor, it is considered a fall, and you have to fill out an incident report. And that is it as far as for your notes portion. Make sure you check out the skills videos also.